Pancreatic cancer is on track to become the deadliest form of cancer in the country. Let's learn how it's treated. I'm Lee Kelso. This is HealthCall Live Online, the place for extended versions of interviews you hear on our weekly radio broadcast, the HealthCall Live Radio Hour. Our subject matter specialist and guest this hour is Dr. Ahad Sadiq of Fort Wayne Medical Oncology and Hematology. He is board certified in internal medicine, hematology, and oncology, and he has a research interest in solid tumors, particularly lung cancer, but he also treats pancreatic cancer, and he just told me on a monthly basis. So it's a hot topic. I'm glad you're here to talk with us about it.
Thank you, Lee. Thank you so much for inviting me and hearing my perspective on this disease.
You bet. So we know now that pancreatic cancer is a sneaky form of cancer and early detection is the key. Tell me the story that patients most often tell you about how they discovered this cancer.
So Lee, it's a very difficult and I would even say a very deadly disease. The unfortunate part is that when most patients present to us on the medical oncology side, their symptoms are very vague. Weight loss, painless jaundice, some abdominal pain kind of going into the back. So these are very kind of a non-specific symptom, which can just be some acid reflux type of symptoms. And a lot of patients kind of think that, okay, let's just see how things go. But eventually, a lot of times when the pain gets out of control or the jaundice really kind of the family member starts noticing the jaundice, they eventually kind of get plugged into the system and trying to figure out that what's going on. And mostly some sort of a scan gets done and they find a mass around the pancreatic area. And that's the time when most of the patients present to us.
So out of all of those symptoms, is there something that I should just jump right on and be insistent with when I see my family physician?
Painless jaundice, that you're not having any pain, and the family member or somebody else notices jaundice in you. And if the pain starts happening, and if you notice that the pain, we kind of use this word that it's almost boring from your upper part of your abdomen going into your back. And if it feels like that to you, that's something I think you definitely should immediately let the primary care doctors know.
So the pancreas is it's an organ about the size of your hand that lays kind of sideways behind your stomach. It does a lot of things, among them producing some hormones, and is very active in digestion. But what is there about that organ that makes it so difficult to treat cancer there?
There's a lot of blood vessels, major blood vessels, including your IVC, inferior vena cava, and some major blood vessels going to your liver, kind of goes right through that pancreatic area. And then there is a bunch of nerves, which we call them a celiac plexus, that also sits right in that area. So a lot of times it's not actually the size of the pancreatic cancer, it's actually the location of the pancreatic cancer that makes it very difficult to surgically remove. And that's where you really have to have a very trained surgeon to even touch those kind of cases.
Yeah, and then they're going to do a procedure called the Whipple procedure in most cases that removes a portion of the pancreas, also the first part of the small intestine, and I think some bile ducts. But I have to catch it pretty early to be able to have that surgery, right?
So the surgery is only an option if the surgeon thinks that he can completely remove this cancer. If a surgeon has an issue that if the cancer, no matter how small it is, if it's attached to one of the arteries, there's no way that the surgeon can snip the arteries. So it's the location a lot of times that determines that if the blood vessels are not involved and if the disease is only localized in that pancreatic area, only then the surgery happens. Even if the surgery happens, out of 10 people, in about 5 or 6, the cancer normally comes back, even after such a major surgery. So it's a very, very difficult disease to treat just because of that location and that aggressive biology of that cancer.
Well, you just mentioned the biology of the cancer, and that's important, I understand, to understand, because not all tumors are the same. Explain to me how that works, how that understanding the tumor biology guides treatment.
So, Lee, I would say probably 10 years ago, it was like a recipe for everybody that there's this one pancreatic cancer, everybody gets treated with the same type of a treatment. I'm talking about chemotherapies and all. In the last 5 years, or maybe a little bit longer, last 5-7 years, there have been amazing progress. And you might have heard the word of precision medicine or personalized medicine. So now the way we look at cancers is that we actually look at the type of mutations or the type of genetic defects that the cancer has in its growth. And from biopsies, tumor tissues, we can get all that information. These days, actually, we look at more than 350 genes at an average on these cancer cells. And then we try to figure out that what type of mutations each person's cancer has. So one person's pancreatic cancer might be a little bit different from the other. So once we find out that mutation status and the mutational burden, then we actually design a plan depending on those mutational burdens and on those mutations. So it's just getting a very personalized medicine era these days, that everybody has a plan tailored to their type of pancreatic cancer or their type of mutations. Before, we didn't know about these things. So it's just a very exciting era for medical oncologists to treat these cancers. There's a lot of progress going on.
And I understand also that we're looking at using our immune system, immunotherapy, to attack these tumors. Can you give us sort of just the big picture on that and how that fits in?
Oh, definitely. So this has been the big, I wouldn't say that this is the magic silver bullet right now, but it has massively changed the direction of cancer treatments. I'm talking about immunotherapies. So the way I would explain immunotherapies to you, Lee, would be that think of chemotherapies as these very aggressive poison-like treatments that people get. But these chemotherapies, they preferentially go after cancer cells, or they preferentially go after rapidly growing cells. So it's kind of more of a generalized treatment when you use chemotherapies. Now, immunotherapies is a little bit of a different idea. We've always thought on the research side in cancer that why does your own immune system not go after cancer? Whenever you get sick, whenever you get pneumonias, infections, your body fights those infections. Why does body does not fight your cancer? So eventually, some research happened, and these gentlemen got actually Nobel Medicine Prize for that. And they eventually figured out that what cancer cells do is that they would actually hug your immune system. So they would be sitting right next to the immune system and almost telling your immune system that, hey, I'm your friend, don't touch me. And right underneath your own immune system, the cancer keeps on growing. So then with research, we have developed these immune therapy drugs. What happens is that these drugs don't let these immune systems hug the cancer cells. The cancer cells are almost dangling next to the immune system. And then suddenly your own immune system wakes up and it's like, this thing doesn't look normal to me. I better should take care of it. And that's where your own immune system goes after the cancer. So a very novel idea. I think our medicine wasn't advanced enough 5-10 years ago. But now I think we're getting to the point where we are training your immune system in fighting the cancer. And this is just the beginning. I'm very hopeful that in the next coming years, we are going to make more and more progress on this side.
Well, you've got my curiosity up. So then do you use that immune therapy with chemotherapy combined, or is it one or the other?
Right. So still, I think we medical oncologists are also trying to figure out these regimens, these combinations. But in pancreatic cancer, I'll tell you one thing, that at this point, as we speak today, I'm hoping that I'll make myself wrong in the next couple of years or in the next couple of months. But as we speak today, the only cure for pancreatic cancer is the surgery. All the other treatments are with palliative intent that they can make people live longer, but they don't cure the pancreatic cancer. So the first and foremost thing is that anybody who gets diagnosed with cancer, can we get them to surgery? A lot of times I told you, with all those blood vessels, with all those nerves or the location, you can't do surgery immediately. So those type of cancers, we call them as borderline resectables. In those cases, normally what we do is that we use chemotherapies and radiation therapies to try to shrink the cancer away from these major blood vessels, and then bring our surgeons to take the cancer out. In situations where we know that the surgery is not an option, either the cancer is too advanced or the patients are too frail to go for surgery, that's where the chemotherapies comes in. For immunotherapies, at this point as we speak, there are certain guidelines about the tumor mutation burden, or there are certain tests that you can check that would the patient respond to immune therapy or not. And if they have those tests positive, then yes. There's a particular test I can tell you called MSI, microsatellite instability. And if you have a lot of that instability, that actually gives you an idea that immune therapy is going to be effective in these patients. So yes, at this point, we're using them separately, but in a lot of other cancers, we are actually using combination of immune therapies and chemotherapies together now.
You know, people sometimes feel as though they need to head out of town to a major research hospital or cancer center to get the most current, up-to-date care. Is that necessary? Are we up to speed here in Fort Wayne?
So I'll give an answer to this question in two parts. Going to a bigger academic center always gives you a reassurance that, hey, I got a second opinion and that big academic center is telling us the same thing, or maybe they might tell something different. But in Fort Wayne, I can tell you two things. How should you treat cancers? One is that, do you have the surgical expertise? In Fort Wayne, definitely yes. We have a fellowship-trained, board-certified surgeon who is specialized in only doing these Whipple type of procedures. So he has spent all his life in doing only these type of surgeries. He is equivalent to a surgeon sitting in University of Chicago or IU. So that part, we have covered it in Fort Wayne. The second part comes up is that, hey, do you have something latest and greatest available? So the clinical trials is a very big program that takes a lot of effort in developing. And luckily in Fort Wayne, Lee, you'd be kind of surprised to know that we actually do clinical trials in collaboration with the University of Chicago, which is very well known for cancer, and UCLA. So what I tell a lot of my patients is that you have the opportunity of getting on clinical trials, which somebody who is a multimillionaire sitting in Hollywood, we have the same clinical trials available, what are available at UCLA and University of Chicago. Those studies could be done almost as a satellite clinic here in Fort Wayne. So I'm a big researcher and I'm a big proponent of clinical studies. So I can tell you that for the sake of peace of mind, definitely yes. But can we provide the same level of expertise for precision medicine, for mutation testing, and for clinical studies? I can definitely assure you that yes. If somebody is up to date on their clinical studies, and if you have those options available in a setting, that kind of tells you that you have good options available. I would say that we are at par. We are at par, yes.
Well, that's comforting. That's good to hear. So when it comes to you mentioned a second opinion. When it comes to a second opinion for any form of cancer, how important do you think that is? And what are the questions that I ought to be asking for that second opinion?
Good point, Lee. So I would look at it in two ways. Now, in the field of medical oncology, we oncologists are very open to that idea of second opinion, and I'll tell you how. There are these gurus in Midwest, on the East and West Coast, that have spent their lives on one particular subtype of one cancer. So when you need that sort of an expertise, we always have connections with these type of doctors. So if somebody, or at some point, if I have a limitation and if I feel that, or if any of our oncologists in town, if they feel that maybe I should get a second opinion to figure out that if we are treating this patient rightly, then actually what we do is that we will actually connect with those experts, those world leaders in their fields. And most of us actually have them on speed dial with us. So we'll connect with them and we'll kind of discuss the case with them. Or sometimes we'll just do, these days with COVID-19, we'll do a telemedicine with them. Or we'll send the patients out to IU or to Chicago or to Cleveland Clinic, wherever we find those specialists. That's one part where we actually, from our side, we would initiate that process. The second part is sometimes for the sake of patient and their family's comfort, just for them to be comfortable with that idea that if they are getting the right treatments, because Lee, to be honest, you are dealing with somebody's life. Somebody with a pancreatic cancer, it's not a normal flu or a sinus infection that you'll be like, okay, take this antibiotic or that antibiotic. You are dealing with somebody's life. You're dealing with a family getting disrupted by this cancer. So when somebody goes out, basically the main question to that second opinion person always is that this is my oncologist, this is what the plan is. Do you concur with the plan, or do you think something different should be done?
Okay, so I take my plan from my original physician, take it with me to that second opinion.
A lot of times, yes. And a lot of times, what happens is that at the second opinion, they actually would just be in touch with that first oncologist, and they would actually talk to each other, and they'll say that, okay, the plan is the same. Or if they have something different to offer, then they talk with each other and they come up with a plan together in letting the family know that, hey, maybe that academic center has a better option, or maybe a better clinical trial available. That would be an option, or they have a better surgical option available. So those things actually are very common in the field of oncology. And again, in the end, it's somebody's life that you're dealing with, and there should be no egos in thinking that, hey, maybe my plan is not as good as somebody else said. Eventually, if you can do something to make patients' life better, period, that's what it counts.
We'll leave it there. Appreciate it. Thank you very much. It's Dr. Ahad Sadiq from Fort Wayne Medical Oncology and Hematology. And in the background there behind him, you see a list of cities, communities in Northeast Indiana where they serve patients and actually see them in their hometowns. And I think that's important for people to understand as well. Good. Thank you, Doctor. Appreciate your time.
Thank you so much, Lee.